now move on to our next presenter, Dr. A-ROP Krishna Chaudhary, who is going to share with us the management of aggressive form of ROP.
Honorable panelists, respected audience, very good afternoon. I am Dr. A-ROP Krishna Chaudhary, working as a junior consultant of Retina Department of Isfahani Islamia Institute and Hospital. Today I am going to present mainly managing aggressive ROP with double therapy, with anti-VEGF and laser. I am going to tell a case story of a newborn baby whom we have examined him in 29 days of his age. His gestational age was 32 weeks, birth weight was 1.5 kg. He has history of NICU admission for 9 days. He received oxygen, received blood transfusion. Within that time, he developed neonatal sepsis, and bilirubin was also high. So on screening, baby blinks to light, pupil was well pharmacologically dilated, and anterior segment revealed normal. This is the fundus picture, red cam image of that baby. Here we are seeing that dilatation and tortuosity only in zone 1 in both eyes. Here zone 2 and zone 3 all are avascular. So we diagnosed him as a case of aggressive retinopathy of prematurity in both eyes. And we decided to give him injection anti-VEGF. So as we know, anti-VEGF in case of ROP, we give half of adult dose. And as because he's at that time 1 month of age, distance from, sight of distance from limbus is 1 millimeter. And in case of ROP, we push the injection just vertically, not obliquely. This is the next day follow-up. No injection related complications was there. And on second follow-up, after 7 days of injection, plus was quite regressing. And on third follow-up, that means 1 month after injection, vessel was quite migrating and plus was regressing. So we wait another 2 weeks. This is the 1.5 months after injection. Here we are seeing that in this picture, vessel was migrated to zone 2 posterior, and few areas in zone 2 anterior, but still plus was persisting. So we on that day decided to go for laser photocoagulation. We did 360-degree barrage laser, 360-degree ROP laser on peripheral avascular area. So this image taken with red cam 2 after 2 weeks of laser, where plus was regressing, and this is the after 6 months follow-up. Then ROP was totally regressed. Then we plan for referral to low vision care and pediatric ophthalmology department for visual stimulation and refraction. Now moving on to the few basic understanding of aggressive ROP. Aggressive ROP is distinct because it is a differ from classical ROP. It has a atypical morphology, fast progression, and it doesn't follow the classic stages and has poor outcome. These are global trends. 5% aggressive ROP is 5% of all ROP, higher in low and middle income countries, and disproportionately higher rate in South Asia and sub-Saharan African countries, as because of inappropriate neonatal care and sometimes unregulated oxygen therapy. Though ROP and aggressive ROP share common risk factors, but we are observing that aggressive ROP develop in extreme premature infant, very low birth weight, where there is unregulated oxygen therapy and poor postnatal weight gain. The management paradigms, unless complicated with stages with 4 or 5, the management option are anti-VEGF and laser therapy, but our focus is on this double therapy. The available anti-VEGF are bevacizumab, ranibizumab, and aflibercept. Initially, the advantage of anti-VEGF are it has rapid disease control, preserved peripheral retina, and in case of very posterior disease, in like zone 1, So we can say that anti-VEGF is a game changer for rapid stabilization in case of aggressive ROP, though it has limitations like recurrence risk, risk of systemic side effects, risk of endophthalmitis, and in case of anti-VEGF, not well-known long-term study is done. So laser is still the gold standard. We do with indirect ophthalmoscopy. Recommended laser is diode laser. We also use green laser. Limitations, we know that laser causes peripheral visual loss. It is technically challenging. And in case of this kind of ROP, like in zone 1 or very posterior ROP, laser is difficult initially. So this is the synergisticity of dual therapy. So anti-VEGF initially causes rapid stabilization, improves clarity of the media, and facilitates laser delivery system. And laser therapy later prevents recurrence and reactivation. These are few supporting journals. So on this type of ROP in posterior or zone 2, zone 1 ROP, first anti-VEGF, if anti-VEGF use single or alone, then we are observing that in peripheral retina is still avascular, in zone 3 or zone 2 anterior, and few plus persist. So that, in this type of cases, if we put laser, then it prevents recurrence and reactivation. So the key message is early detection is critical for aggressive management of ROP. Anti-VEGF stabilizes and laser ensures durable outcomes, and close follow-up is essential. These are my acknowledgements and references. Thank you.
Thank you, Dr. A-ROP, for once again proving that offense can sometimes be the best form of defense. That is, the aggressive manner of intervention can actually stabilize rapidly the aggressive form of ROP. Now I would like to invite Dr. Mohammad Arifuzzaman sir to say a few remarks.
Thank you, Dr. A-ROP. You have nicely presented the case, and the management of a patient of aggressive ROP was excellent. And I really feel proud today. You is one of my students who is now, I have gone Islamia last few days back. I have seen him operating on a ROP baby. That is the best thing I could ever achieve in my life. I have thought on that day. I didn't say it to him, but that is really excellent. It is, this is one of my passion of treating these vitreoretinal diseases. Though I don't do it nowadays, one of my patients has actually died when I was doing laser. That was a very devastating event of my life, and I have left doing ROP. But still I salute to all the ROP doctors who are treating ROP. They are taking real pain actually. It is not only physical pain, it is also a very difficult mental pain also, treating ROP babies. And thank you for the doctors who are treating these babies. It is excellent job. And what I want to say about the challenges of treating ROP is not only with the retina specialist. It is a subject of basically social people also. All doctors, all gynecologists, pediatrician, even guys or non-doctors who are delivering the babies, all are involved in this case. Because if they do not refer a patient to appropriate time, that also loses the cases. So it is really difficult to give a proper treatment for ROP diseases. And also for the doctors who are treating ROP, I am just having a request, please always ensure about your own safety for treating these babies. Many of the young ophthalmologists I know, you will be coming into the subject, but always remember about your safety, because these babies are very vulnerable. They can die anytime, actually, because these are many patients. Sorry, sir? Yeah, written consents, even keeping a neurologist, anesthesiologist. You should get all your safeties for your treatment. This was all I wanted to say to you, and thank you very much. Our sirs, teachers also are still here after lunch. You are taking real pain for attending the session. So thank you all. Thank you. Please, sir.